are familiar with this, but there are times where we experience video and audio issues. If that happens, try closing apps and refreshing browser so that we can optimize our experience today here. So I am really excited that we have a fabulous panel of industry experts today to kick off our conversation. So I will turn it over to Jill Fasano from Teleperformance to do some introductions for us.
Hi, thank you so much, Linda. So I want to first and foremost thank our panelists and obviously everybody that has joined us. This is a very exciting initiative for all of us, especially from intelligent healthcare and what we're living in today. I would like to first introduce our team here that has joined us. I'm going to start out with Jeff Heshme. Jeff, would you like to introduce yourself?
Yeah, no, you bet. So my name's Jeff Heshme. I'm part of the Teleperformance Healthcare Solutions team.
Thank you. And I want to thank Margaret. She has put this together. She's going to be in the background, but she has really set aside and done just a phenomenal job. So I wanted to thank her for that. And I'm Jill Fasano, for those of you that don't know me. And I am part of the telehealth initiatives going on with our organization, working with the digital health and the entire healthcare sales team. So I want to start out first by introducing the panelists. Deepak, would you like to introduce yourself?
Sure. Thanks, Jill. Deepak Dubey. Very briefly did my PhD from Chicago, then was a researcher at Bell Labs for a very long time. Then the entrepreneurial bug bit and Data Nomers was formed. It's an AI/ML, particularly transparent machine learning company with lots of applications in finance, retail, healthcare. So I'm really glad to be here.
Thank you. Bob, would you like to introduce yourself, please?
Sure. Welcome, everyone. Glad to be here with all of you today. My name is Bob Rowland, and I'm the President and Chief Operating Officer of GrainRx. We're based out of Pittsburgh, Pennsylvania, but we service seniors, and when I say seniors, I mean seniors, folks that should be in nursing homes, but given their situations and programs they're in that we service, like the PACE program, they're at home, right? So we ship to about 12, 13,000 residents, participants, patients, depending on the setting, each month. And we do that through our Meds at Home program.
Thank you so much. And Lisa, would you like to introduce yourself, please?
Sure. Hi, good morning, everyone, or good afternoon, depending on where you are. I am currently the Chief Revenue Officer for Preventric, which is a digital health medical device company in Birmingham, Alabama. I also work with HitLab as a fellow, and they're just a digital researcher consulting group. Throughout my healthcare career, which is, I guess close to 30 years in total, is been on several sides of healthcare in the practice management space, EHR, and then clearinghouse, so a lot of provider experience, and then moving over to payer and pharma and now medical device. All of that has always has given me kind of a unique perspective, I think, on looking at across healthcare. Most of the roles have been product management and strategy, but I also was a chief experience officer for several years with a payer-based company called DST. So I'm really looking forward to this discussion. I get really excited about this. So look forward to digging in with everyone.
Thank you so much, Lisa. So we're going to actually start off with you. The first question, what I'd like to ask you is, where does technology play in the overall human interaction in creating healthy outcomes?
Yeah, so this is so much fun. So, technology really allows us to streamline areas that we couldn't before. That's one of the ways that I think about it, is like, without technology, it takes out that let me say it a little different. It allows us to automate things so that we can focus back on the human interaction. So as an example, let me just start with call center, because that one's one that's easy and it's fun for us all to understand. Think of the technology is something that can be enabled. So now we can start to predict voice, we can look at sentiment, we can automate process, we can do a lot of amazing things with technology, but that allows us to still be humans and understand it. And without understanding the people that we're designing it for, then we wouldn't have the same solution. So I'm a big believer in using human-centered design thinking as a way to understand what the process should look like, mapping out that experience, interviewing, a lot of empathy interviews that allow you to develop the technology and the solutions on the back end. I'll use another example, which is just the current one in the medical device space that I'm in. We actually focus on an area in hypertension that everybody should be familiar with this. Just go into your doctor, and the way hypertension is typically diagnosed is by placing a device on you in the office, right? A cuff, and then if the doctor suspects that you have hypertension, they may send you home and you may log it for a while there. Well, a lot of our doctors tell us that often the patients will say, no, doc, it doesn't matter what it's reading in the office. I don't have hypertension. And they will have a discussion and an argument about it. But we have a device that allows them to send it home with the patient, and they wear it for 24 hours. So you can't argue with 24 hours of data that's being collected, because not only is it giving you insights that they would not get if they were monitoring themselves or they were getting in the office, but it allows them to say, I know what you think you're seeing and that it's different, but now we're going to tell you exactly what it is. So it takes out that bias that we often create. And then, of course, it gets really even more exciting now that we have that data from 24 hours, that we can start using that to predict future disease states and cardiovascular events that are longer stream. So those are just a few examples and areas that come to mind for me.
Wonderful. That's awesome. So Deepak, this obviously leads into a little bit with you. So we're always focusing on predictive analytics. We're focusing on areas on how we can prevent and really go forward in the future to have more information, to be able to stop, if you will, areas that are going to be very severe. So from cohorts to different areas. So Deepak, this is your area, and I'd like to hear more.
Well, thanks, Jill. By the way, can everyone hear me well?
Yes.
Okay. Lisa gave some really good examples. And there is a broad category. She mentioned automation, streamlining. Those are key concepts, irrespective of the technology, certainly in AI/ML domain. By that, I mean artificial intelligence, machine learning. Certainly in the machine learning domain, but she mentioned the business objectives, right? It's under this broad umbrella called digitization of healthcare. So let's parse this a little bit. So I'll start with what Lisa very eloquently described. Automation, using techniques like RPA, AI, machine learning models, heck, even expert systems, traditional programming, rules, bunch of rules to be followed, right? It goes a step beyond that. Sometimes people do process engineering to remove the kinks in the overall workflow so that it's streamlined, to quote Lisa. And so therein you've got, in that streamlined, automated workflow, you have the ability to reduce costs, be consistent with customer service, and those are key objectives. But we can go to digitization 2.0 using machine learning, which is how about use the enormous amount of data that healthcare collects, mine intelligence from it to better deliver healthcare to the constituents, to the patient. So in other words, yes, you've streamlined the workflow and it's many more cases are being patients are being seen and healthcare services are being delivered, but how about uplifting the quality of service that they experience by using data-driven or maybe data-assisted decision-making? And that is where machine learning really comes into its own as part of digitization 2.0 of healthcare, where it mines the intelligence to better the experience and outcomes. And I will, as the conversation goes on, I'll jump in with specific examples. So that's one part, the x-axis, if you will. And there is the y-axis. So we mentioned machine learning and how it mines data, but it takes off right from there. Critical to any sector that is as important and regulated, tightly regulated like healthcare, is the requirement that any technology has to necessarily meet the regulatory requirements. So for machine learning, that means it must follow ethical principles. And within that realm, one thing that we focus here a lot is transparent machine learning, where the everything that the machine predicts, recommends, provides insights is above board. Not only does it tell you its pronouncements, but also the insights and reasons behind it, so that you as a provider, you as an insurance provider, you as a patient, everyone is in complete sync and agrees with the best course of action. And then there is the z-axis, last but not least, for how technology is going to significantly impact healthcare. You know, we are headlong entering into an era of sustainable green credentials, and healthcare is also impacted by it and will be impacted even more so. So if I were to borrow that term, right, ESG, environmental, social, and governance. So healthcare practices must be environmentally friendly, yes, of course. Social considerations, making healthcare accessible to all. It's not a luxury, it's a basic necessity, and so it must be made accessible to all as a societal commitment. And that's very, very pointedly applicable here in the United States. G, governance. Are there dubious practices that need to be above board? Fraud, for instance, in Medicare, Medicaid. And I can give you specific examples of where people have initiated fraud and not been detected, and those that haven't, worse, and have gotten caught. So machine learning to the rescue here as well, because it is able to baseline what a normative behavior is, and then study fraud in context of that norm behavior. So that's the z-axis, and there are many more z-axes, but I'll defer it for later.
Yes, so thank you so much. So what I wanted to do is, so Bob, I do want to hear a little bit from your experience, and we're going to watch our time. But one of the things that's very important, obviously, is how this affects, especially all ages, but from what's happening today in our industry and from patients, and how emotional intelligence in different areas are very important.
Sure. Yeah. In my perspective, primarily going to be from a senior's perspective. That's who we service, and And our goal in terms of healthy outcome is medication adherence, right? I know we've all seen the numbers in terms of lack of medication adherence and the cost to society, cost to business, cost to individuals. So from a patient perspective, I think there's what they know and what they don't know. They don't really care perhaps or understand the technology that the pharmacy, for example, and GrainRx uses to ensure that medications are properly packaged and delivered. They expect that, right? They expect their medications to show up the fourth Tuesday of a month at between 1 and 4 p.m., in our situation. So there's a lot that goes on in terms of us using artificial intelligence, for example, to make sure that the medications are sorted properly. We deliver them breakfast, lunch, dinner in pouches, evening. So we're pre-sorting, and we have machines and imaging devices in our pharmacy that make sure that the right pills are there for breakfast, lunch, dinner, evening. And then once they leave the pharmacy, and this is where the patient really starts to see the technology perhaps, is in our white glove delivery program. So, we've got to get our driver there. And from their perspective, they just want the meds to get there on time. They want them to be packaged properly. They want the driver to be friendly, those types of things. And they're like my mom. My mom's 86 years old in Toledo, and she's set in her ways. And I finally got her to use a GrandPad, right? So that maybe she'll do an email. Maybe she'll do a video call. But for the most part, the people that we see are poor, dual eligible, rural areas. And the most technology we might have, quite frankly, is telephone, right? It actually might be a landline. So that when we do our robocalls, when our drivers are calling ahead of time, they say, Mrs. Smith will be there in an hour. I know I'm running a little late. Don't worry, I'll be there. We just hope they answer the phone, right? So some of this stuff's pretty simple when we're dealing with the patient in these rural areas. But on the other hand, we're heavily engaged technology-wise with the providers. We primarily service PACE programs across the country. So the folks that are in these PACE programs have a very strong interdisciplinary care team across the board: pharmacists, physicians, social workers, priests, rabbis. And there are all kinds of folks on the interdisciplinary care team. So we use technology to try to educate the interdisciplinary care team. But at the end of the day, the technology in the group that we service has to be pretty simple when it's right to the consumer.
So Stephanie, I see you nodding a lot. I'd love to have you, and this is open, so I do want people to join in the conversation. And I see you nodding. So Stephanie, I would love to hear from you. You're on mute.
Sorry about that. Let me just listen a little longer and then I'll contribute. How's that? I'm just kind of absorbing.
So I would love Ravi or Jason, Alex, would you guys like to chime in a little bit? I'd love to hear your thoughts.
I have no questions as such, but it's a pleasure to hear the great work that everybody's doing.
Wonderful.
Jump in, guys. Otherwise, you just hear me all the time. That's no good.
So, well, I'm going to ask Linda to actually share a little bit with the things that are happening in the world today, and very focused, obviously. So Linda, I know you run so many things in our organization, and you are one of the most brilliant thought leaders. So I would love to have you share some information with us.
Oh, I appreciate your comments, Jill. I think that, as I look across the ecosystem and talk to a lot of people in this space, healthcare, we all know we need to automate, but we're cautious in the approach because of regulatory challenges and patient information and HIPAA. And so I think that coming, around through this global pandemic, it's helped companies to try to move a little bit faster and see the results. And it's allowed us, in the healthcare space to really embrace telemedicine, telehealth, a more virtual world. And I think it allows for us to have more efficient operations. We just have to make sure we're as effective as we can be and not automate everything. I mean, we have the whole human element. This is healthcare. This is life or death. These are, we talk to people every day who are newly diagnosed, or they're a caretaker for somebody with a chronic illness, or they have an emergency situation, they require surgery or something that's coming up. And, a lot of those conversations have to be led with the human interaction and engagement, empathy. So I think that's where we all, are challenged, and how much are we going to automate? And when we do automate, it has to be the right interactions for the right people. And there's so much technology out there. And I would love to hear some examples from all of you on how you approach that. What does your technology or your automation or your digital roadmap look like, whether it's 1.0 or 2.0 for Deepak? How do you get started, and how do you ensure to have the right regulatory and compliance rigor and the right human component? So that's kind of what excites me and interests me about getting this talented group of people together so that we can talk through some of these things.
Lisa, you have obviously a lot going on.
I do.
Definitely.
I would love to jump in on this one because it goes back to one of the things that I already mentioned, but I wanted to dig into a little bit more is around journey mapping. So what journey mapping allows you to do when you map out a customer's full journey is it allows you to get outside of just designing software or solution that's very specific to what you're offering. Instead, you take the customer to what problem are we trying to solve? And when you understand the touch points, even if you are not going to necessarily develop a solution that will solve those, you can understand really what problems that you're solving for. And you may even catch something that you wouldn't before. So just as an example, just different solutions I've worked with over the years, where if you use ethnography and actually watch people in their place of business and watch how they may be interacting with the software, you'll see that, every other step where they pull out a notebook and go, oh yeah, that's a code that I need, or they go to another website even, or you can see where the frustrations come in because you're seeing all the different interactions that are outside of what your software can do. Journey mapping even takes that to a broader level because it says, just go back to our patients and our members, right? The experience doesn't start when they walk into a doctor's office or to a hospital or call their health plan. Their experience starts when they have a problem, or they have a problem for their parent or their child or whatever. That's when the experience starts for them. And it doesn't stop once once they're done with you, then they go on. And that's why I love that Bob is here too, and how we all have a different perspective, but extends to the pharmacy and interaction with their drugs. So it's every little piece. So understanding that ecosystem, understanding what your customers whoever your customer is and whatever perspective that they have, understanding what that is. So I know that's a little bit different maybe than what Linda asked, but just one other comment to tie it back around regulatory, because I know Linda brought that into, and as far as your transformation roadmap efforts go, that's another area in call center, because we do have the ability to analyze data and voice and sentiment, is using that as part of your regulatory roadmap as well, and predicting risk and compliance efforts and areas that may be escalated to a grievance or appeal type of thing. So you can be a little bit more predictive in your way of listening and looking at data. So those are just some of my thoughts of just making sure, again, you're starting back with the customer themselves as you're applying how you're going to transform that and apply it to your roadmap.
Absolutely.
One particular example that jumps out with me is what Lisa had mentioned about blood pressure, and the fact that patients say, "Oh, that's not me. That's just I'm nervous because I'm at the doctor's office." So you're registering high blood pressure. That's not what it is typically. So think of Linda, all the wearable technology that we have today, right? And so they are capable of monitoring with some reasonable degree of accuracy what your blood pressure is, what your pulse rate is, what your skin conduction is, what's the perspiration, and what that reflects in terms of health, a whole bunch of parameters, right? And so let's just focus on blood pressure. So let's say it's continuously monitoring it, and should it exceed certain thresholds, it alerts your primary healthcare provider. And so if it does that, there is a challenge. And this is why these things haven't taken off. The challenge is that parameters are defined very strictly in healthcare. Like, for instance, a normal blood pressure, systolic diastolic, is 110/72 millimeters of mercury. Well, does that mean that if it's 112/75, all hell should break loose? No, not really. It's a line in sand, and if you're unfortunate to fall on this side or that side, 71 versus 73 ain't different. And so therein lies the challenge with automating these things and continuously monitoring it, because you would have a flood of false alerts to where your primary care is going to say, pull that plug, please. All right, you were 118/75. There's no reason for you to rush to me. All right. I just keep getting these alerts, which makes no sense. So what it needs is AI/ML to step in. In particular, a technology of machine learning called anomaly detection, which is graduating from the hype cycle to the magic quadrant using Gartner terminology. Because now what can happen is it doesn't presume anything. So it's taking Bob's blood pressure from his wearable and sending it to his private virtual cloud, maybe where he keeps pictures of his grandkids on the Apple cloud. And as it takes that, it builds the norm of how Bob's blood pressure behaves throughout the day, right after his meal, when he's done walking, just before he goes to bed. There is a complete multivariate distribution that anomaly detection builds of how the blood pressure behaves. Once that baseline is established, when the new readings come in, it will first check to see if there is significant deviation from the built norm for the worse. And only if there is, then your healthcare provider is alerted. So if Bob's blood pressure typically is 80/130, that's for argument's sake, right? And that's okay for the cardiologist, for instance. Then that's okay. As long as it's in that range, it's not alerting the cardiologist, sending out messages. But if it one day it moves up to 138, and the bottom one is 88, 138/88, that's a significant deviation from the multivariate distributions it's built for. After lunch, maybe that's fine, but in the morning after exercise, maybe that's fine, but during the day, it shouldn't be 138/88. So says the norm. It is, alert the cardiologist. And you imagine the power of preventative medicine. Rather than rushing, and every 39 seconds, someone has a stroke or a heart attack in this country. Imagine rushing to the emergency when it may be versus proactive health. Incredible what anomaly detection can do. Let's take an example of what Bob said. It left a lasting impression with me last time when we were talking. He talked about this colleague of his who heads nursing home and who's so frustrated that people get upset that they start to threaten that their mom's not being taken care of. Why is that? It's because things are not transparent. Even if you're taking the best care, people in darkness assume the worst. So ethical/transparent machine learning, where not only is it recommending these are the things we are doing, why are we doing these things? Why are we not doing those things? Why are these things important for your mom? As long as those things are listed and out in the open, which machines can now do, intelligent machines can now do. It's called explainable AI, by the way, as also augmented intelligence. These are two big pillars of AI ML. As long as you do those things, the people on the other side see perfectly well how their mom's being taken care of with expert considerations and why these considerations are supposed to work and not the others ones being chosen. I think to a great extent, people would be satisfied and not assume the worst. And then obviously we can couple that with empathy and all the other mechanisms, which we can talk about at length as well.
Yeah, and Deepak, how do you build? I like what you're saying. I do believe those things can be done or will be able to be done in terms of monitoring. But how do you build patient choice or preference? Right? I mean, taking care of people at home, I suppose, might call it the last great frontier, right? It's a whole lot easier to care for people and monitor people when they're in a hospital or emergency room or a nursing home, and maybe even under home health care, typical services. But you start monitoring things day to day and looking for anomalies. People have opinions.
That's right.
I was just seeing my mom in Toledo, and like I said, she'll be 86 in May, and she said she had a cold. And I said, Mom, it looks a little more than a cold, right? That cough doesn't sound good. Oh no, it's a cold, leave me alone. It's a cold, right? And I said, no, we're going to the doctor. And if I hadn't been there, she probably wouldn't have gone to the doctor.
Yeah.
And I get there and I said, Mom, can I go in? No, you can't go in. She doesn't remember what she had for breakfast because I want to hear what's going on. She came out, she said, yeah, I got a cold. And I said, can I look at the paper they gave you? She said, yeah, it said acute bronchitis. Right. So, when it's to your point, the physicians and the providers don't want to message every 30 seconds on things. And especially older people, I think, want to be left alone. They want privacy. And if you push those buttons too hard, they're going to unplug their devices.
That's right.
Right. So from an AI perspective, how do you tell the machine, I know I'm a diabetic, but I like to have a piece of cake at night. And if my blood sugar shoots to 400, I'm not going to the emergency room. I'm just going to do those things, right? So I think that piece of it is just as important as to knowing the medical state of someone.
That's right. Excellent point, Bob. So you eat a piece of cake and your sugar shoots up, and that is the norm that the machine learns.
Mm-hmm.
And so if you continue to eat a piece of cake at night at par for course, that's still the norm. The new statistical signature that the machine generates day after day still resembles, the two look pretty much alike. The evening spike in sugar is reflected in the new statistical signature as well, and so nothing to worry or alert, because that's the understanding between you and your provider, primary care physician. There is a concept I'd borrow from finance. It's called open banking, where people, especially it's become popular in Europe, especially, and along with it came a whole bunch of requirements around data regulations, where people opt in themselves. I want my this financial information to be available to this app provider because it knows to look for good deals on Roadrunner bikes when it's available and provide me reasonably good financing deals. So they opt in. So similar concept. I know it's difficult with anything to change in terms of these strict regulations in healthcare, but I think what similar concepts need to be there. And then the other thing I would lastly add is there are patients who are normal, who may not choose to opt in. And then there are patients who have a higher risk category, maybe because of age, maybe because of some conditions. All of us were acutely aware when COVID struck of who were in the not so desirable or who had immune issues like autoimmune disorder, for instance. So there are those who are in the riskier category. Their doctor maybe should say, you should opt in for the open banking, open healthcare
Right.
equivalent model.
Right. So Deepak, let me ask. So Stephanie or Jason, Ravi, are you guys, I would love to hear from you. Do you guys have any questions, or would you like to share anything that is, happening today and what you're doing?
Yeah, I'll just share just a little tidbit about some of the conversation that I'm personally relating to, and that is the measuring and the trends and things like that, because I do a lot of measuring of, I measure my blood pressure twice a day, my temperature twice a day, my weight every day, et cetera, et cetera, et cetera. And I get a lot of blood work and stuff like that done, immune disease. And so it's interesting because what's okay for Bob might be completely different for me. But there's a range that says your progress level should be between this and this. And that's okay. I might be closer to this side where Bob might be closer to this side. And based on everything else about Bob, he's supposed to be. It's okay for him to be closer on this side. And so it's the individual piece of it that I'm really kind of relating to.
Yeah, exactly. Each one is wired differently. Very well put, Stephanie. Yep.
Yeah.
And that's
Yeah,
what
we're wired differently, but we also have different expectations on what quality of life means.
that's right.
Right, so how do you tell the computer, the robot, this is what I want from quality of life. I like to play with my grandkids. I like to go get my mail. I'd like to be able to watch Dr. Phil for an hour. Right, these are things that I want to do. Not me. This is my older patients. I'm not there yet. These are my mom and these older patients, and they say, okay, well, based on that quality of life, here's what you need to do to take care of yourself. You need to walk up and down the steps once a day in your house, or you just need to do things to maintain that quality of life. I don't want to be a marathon runner. I don't want to go to the emergency room anymore. It's okay if I'm only going to live another year. It's about the quality of life that I think the care plan has to be built around.
Yeah. So Stephanie, let me ask you a quick question. So regarding, are you currently using any type of like AI with, remote patient monitoring, telehealth, and
No.
okay, and why not? I would love to hear.
Danny, I don't think I can answer that.
Okay.
I can try to get some additional information, but I don't think I'm really prepared to answer that.
So, well, one of the things is like emotional intelligence, and there's a lot of, patients for everybody, I call them consumers, if you will, that experience these types of things that are happening every day. So I know personally, if I had, my mom had passed, but if I know, she would be like, I'm not doing this. Like, it's one of those things that you have to engage, like, and we do a lot of things with AI and emotional intelligence, especially from gamification to interaction. So how do you personally want to interact? And that's, I think, that goes back to what you said earlier was, it's a personal thing. You're not like Bob. You're like, you are Stephanie, and that's what you are. And you're able to personalize this to meet your needs.
So we did do some piloting with some emotional intelligence software, if you will, and we actually piloted it for quite some time, but we really couldn't get it off. We couldn't get the benefit from it, to be honest with you. And certainly we weren't getting the ROI from it. And so after we tried to kick the pilot off, basically we did 3 pilots. Of course, we had COVID in between there, and our whole world changed from working in the office to working at home, and so it kind of messed our result. I mean, so it was really, when I say we did 3 pilots, that's probably not fair because there was just so much happening. But in the long run, where we ended up was that we weren't getting we weren't getting the ROI. And so we didn't really, choose to continue with it.
Wow. So one of those things that, I absolutely like, thank you for sharing. I really appreciate that. Ravi, I know you're more from, if you will, the technical aspect. And can you share like what your experience has been so far with like interactions and throughout the areas of what you're doing today?
Yes. So I think I'm more in the product management space as such. I work for Oracle, and we are working with Deepak's organization with Mita and data nomers, EasyML. I think I agree with Deepak that ML and AI introduce a whole new kind of a different paradigm to the way that one needs to look at things and the possibilities that are there. I also can relate to the challenges that Bob highlighted in terms of so in the end I think it becomes a question of how do you bring the human element together with AI and ML to produce real practical solutions that are useful. And of course, Lisa brought up some very good points as well. So it has been a great discussion. Love to participate and listen in primarily.
I love having you. So thank you so much. So, and the one thing that's probably going to be like a little off course, but, really looking from the area with, I know Cerner and some of those other things, those are areas 100% with, telehealth and some other areas that are going to be impacting, especially from healthcare systems, globally, and what we're doing today. So I had the pleasure of meeting with Dr. Feinberg and some others from Cerner, and, especially with the merger and how those are going to change from a technology perspective, which is very important.
Hi, Jill. This is Meeta. I'm sorry I joined late. I had a conflict. Thank you so much for putting this together. I have a question, if I may ask.
Absolutely.
And if you have already answered, my apologies. But we see at EasyML data nomers that, like the financial services, healthcare also, some of the organizations are ahead in adoption of AI ML. Some are just starting, some haven't really thought, to adopt these emerging technologies. I would love to know from the panel, what are their experiences? Where would they put really healthcare industry in terms of adoption of AI ML? Where would they put, if there was a spectrum, where would, their respective organizations or the industry in general be in terms of adoption of AI ML?
Lisa.
Deepak's going to have some probably comments on this too. But I always, I think we probably all do. I always put healthcare is lagging in terms of health, in terms of technology and acceleration. But it's not because we don't have smart people, and it's not because the technology isn't there or doesn't fit. Often it's the case of how the money flows and how the incentives where they sit and how the arrangements are. So whether that be in value-based care, or let's talk about bundle payments or something along those lines, where you have to be concerned about how the split of the money is going to happen and where the share is going to happen. Or it could just be our core issue around, interoperability and how the data is shared and who gets the data and how you can use that to accelerate it. So it's not that we can't, it's been business problems that have often stopped it from accelerating. But again, I will go back to COVID and what that has done in removing, because there was also patient barriers in there too. We've got years and years of expectation and a certain way that we've interacted in healthcare. And now that has been accelerated by years just because of COVID and going, okay, well, I don't have an option anymore. I'm going to do telehealth. In the case of, I love Bob's stories too on his mother, because my mom does pretty good for 82, but she never would have opted for a telehealth visit unless she had to, right? I mean, she wouldn't have chosen that for herself, even though she uses her phone. So I think we use these opportunities in these events to continue to build that and to keep that momentum going, and keep using the technology and the smart underlying technologies that maybe we're using in business process, and keep tying the two together. So we may not be there, but we've got room to go.
Thank you, Lisa. Thank you. Are there any use cases that you think are more applicable to healthcare in general that are, being adopted across the industry, or it's still something, that the industry as a whole is exploring?
I think as a whole, I mean, I think some people are doing better than others. I think we're leveraging it in places. I could see it all the way from the back end in pharmacy, where you're using business rules to drive and make clinical decisions, to think of more clinical decision support and opportunities that have been in place and that we are using. But then where the opportunities lie are back on the more predictive side. So we've been, more retrospective in a lot of the data analysis, and now it's time to get more predictive and start leveraging that to our advantage.
Yeah, absolutely.
Thank you. Thank you, Lisa. Thank you, Jill.
Thank you. You are so welcome. So one of the things I did want to ask is, if you guys are coming, especially, Lisa, Bob, Deepak, especially Stephanie, coming from, obviously from, Florida Blues and things, how do you see, if you will, from the front end of the engagement, like getting, patients or, going from members, how do you see that happening? If a lot of people aren't engaging today, and, it's forecasted that, 70+%, by the year of 2025, I know it's been all over the, area within healthcare. So can you share a little bit from your perspective on that, please?
Are you asking Jill of how to get it moving from the adoption side?
Yeah, and I wanted to ask Stephanie on, what they felt was like lacking, if you will, from interaction.
And my apologies, but I wasn't quite sure what was happening with today's call. I'm probably not the best person to be on it to represent. So I'm kind of struggling a little bit with participation. So I am listening and taking notes and absorbing, but limited in my responses.
Oh, well, thank you. Well, you don't have to have like any back. It's just a personal, like I always say, like, if I had my wish, what I would want. So I call it the wish list call. So, well, I wanted to definitely thank everybody for, participating today. We have recorded the session, so please let us know. We'll follow up and have feedback, and we're here. So if there's any questions whatsoever that anybody has, please do not hesitate to reach out. And I want to thank everybody for joining and participating. And I think this is, just the beginning of what we're doing. And I'm very excited about it. So thank you so much.
Thank you.
Thank you. Thanks for arranging this. Lisa, Bob, Stephanie, very nice to meet you.
All right. Thank you guys so much. I appreciate all your time.
Have a great day. Take care.
Bye-bye.
Bye.